I'm really delighted to be back on this call with One-to-One, supporting their work. Superbly done, as we've just heard, and absolutely vital. Professor, can I thank you for your time? Obviously, you're helping too to promote this cause, and it's very valuable time that you have, so we're particularly grateful to you for giving it today. I thought, if it was all right with you, that I might start with a few questions about COVID, the disease, and not just in North versus South, but then move outwards to that. And it's a particular question that I've been worried about, which is, what strategy are we really now on? I'll use this country as an example, but it's a general issue. When we started, there was this squashing the hat idea. This effectively was to keep the capacity of the health service protected, so we'd make sure that the disease wasn't producing hospitalizations that we couldn't cope with, and we'd keep under that level. But under that, I suppose, in the end, you would have had all the infections, people would become infected over time, it'll just be over a longer time. Then there's the alternative strategy, which is effectively suppression. We're going to drive it so low we can contain it through test and tracing. Which of those strategies intuitively seems to you the most sensible for any country, including ourselves?
Thank you very much for that, Daniel. So part of the reason why I have purposely remained silent in the public space on the subject of COVID is, as an infectious disease epidemiologist, I happen to know that we know too little to actually be able to predict what is going to happen. And I am actually quite sympathetic to many of our colleagues that are trying to run the system in many countries and make a difference through national leadership of what is essentially shooting in the dark, as your question quite articulates quite well. There are a number of options you can take. We will not know who is right until 2 to 3 years from now, whether the Swedish approach of letting it roll, or indeed the Korean approach of squashing it and keeping it really low is the right answer. Interestingly, we seem to be doing a hybrid of the two in the UK. And my feeling is not by design, but by circumstance. Decisions were taken with all of those caveats that I mentioned earlier about not knowing truly how this would pan out. Some mistakes were made, and it's easy to second guess some of those, but there will be time to do that. And we're in a position where we have gone through quite an awful peak of the disease with a lot of tragic loss of life. And when we talk about these big numbers, they are misleading, because actually each one of those deaths is a tragedy of a life of an individual, a child, an adult, a grandparent. And that's happened to tens of thousands of people. Recent estimates suggest as many as 50,000 people have died in the UK. Now, going back to your question, what on earth are we doing and where are we heading? I think that what the government is doing here is trying to weigh a strategy that contains the spread of COVID-19 in the UK with being able to maintain an economy that is functioning sufficiently so that in the long run, there does not end up being impact such that the health effects, inadvertent health effects of the economic crash actually are as awful as the disease itself, which is a difficult, tricky balance to strike.
Thank you so much. I'm going to, by the way, start with some of my own questions, and then hopefully people who are listening, who are watching us, will use the Q&A button to send me their questions, and when we've finished, I'll be able to put some of their questions to you. I'm actually married to an epidemiologist, so to the side of my desk is this book, which probably is familiar to you, and my wife's textbook, and I noticed on infectious diseases it's written by Johan Giesecke, and his view, he's a Swedish epidemiologist, his view is, look, you can't keep a lockdown long enough ultimately to prevent disease from spreading, and in the end you've got the same thing.
No, I have my own book, so I'm
right.
on infectious disease epidemiology, and I'll come back to that.
Well, I mean, the thing is that was quite striking. So he is of the view, it's very difficult for the layperson to work this out, therefore. He is of the view the infection fatality rate's relatively low. We can live with the number of people who are going to die, but in any case we have to, because it's absolutely impossible to close the economy down long enough, because vaccines probably not going to come. And then Neil Ferguson says, no, you're wrong. The infection fatality rate is much higher than that. It's impossible for us to live with the number of deaths that would be caused, and we have to therefore we have to shut down the economy. And sure, it might be, he says 18 months, but I don't see why it should be 18 months and not, we still don't have an AIDS vaccine. So the question is, how does one make that judgment? How does one decide between those two views? And how, as a lay person, to everyone on this call, probably almost all of us are lay people, how do we make a judgment as to which of those positions is correct when two very distinguished people can't agree with each other?
So, excellent question, and I will attempt to answer that. So I have great respect for Johan Giesecke and his epidemiological skills and expertise and experience of a lifetime in this particular space, including through his work on respiratory infections as well as infectious disease epidemiology in general. The difficulty is we do indeed know too little about this virus, but the little we know suggests that it is possible to suppress it. So if you look at what the Koreans have done, what the Chinese have done in Wuhan, the difficulty with that approach is we don't actually know exactly among the things they did, what did the magic. People want simple answers like wearing masks, but it looks like they did a number of things. And it's a combination of those interventions that seemed to have worked. I don't think it's necessarily lockdown, because some of those societies didn't actually shut down society completely. They had a number of the non-pharmaceutical interventions. Others, such as Wuhan in China, did actually do a lockdown. And I think there's a path in terms of separation that entails some degree of the non-pharmaceutical interventions, a combination of them, without completely shutting down society, that you avert this toll of mortality that is happening. And if current estimates of the proportion of the population infected through the numerous surveys that have been done in Europe and here turn out to be true, that only a tiny proportion of this country, for example, is infected, and that ultimately, if let to roll through the population, it will affect many more, then the mortality levels would be so high that the view that those on the other side of this debate from Johan, and it's not just Neil Ferguson, there are many who estimate that the mortality rates could be quite high, then I don't think human societies would accept the choice between the needless loss of life that this may cause compared to the pain of shutting down some elements of society, not necessarily a complete lockdown. If you start early enough, you could mitigate it. Now, the alternative, assuming Johan is right, is such that in fact, it takes forever to get a vaccine. I hate the concept of herd immunity, because that's something derived from veterinary epidemiology, where we treat groups of animals as the entity and as economic activity. And essentially, we let the disease grow, and then when a certain proportion is infected, you could protect the herd and the disease does not spread any further. I think if it's my grandparent, my uncle, that is going to lose their lives, I really would not like us to look at epidemiology in that way. I'd like us to see absolutely that every single life is valuable, and can we do enough to prevent this disease from spreading in the population to the level that we can afford to do?
Can I just ask a little bit, because there's obviously the question of delicacy of expression, right? And everyone, I think, recognizes people are angry at the idea that herd immunity should be an objective, but it's a little bit more precise than that. The question is between whether we're, in the end, if we don't get a vaccine, going to have to settle for the fact that it won't end until, I'm using this phrase because I don't know a better phrase, until the herd's immune, versus whether we try a strategy that attempts to prevent it lasting forever. And what you're suggesting, attempts to prevent it and keep it suppressed forever. And you seem to be suggesting you think that there is at least a chance that we could make a South Korean Chinese approach work, and probably that would be a better bet given the risks involved in a Swedish type of approach?
So Sweden is peculiar for a number of reasons. They have a society with a lot more affluence than most places in the world. They have many households where, in fact, there's just a single individual occupying them. They don't have multi-generational households, and they can afford the things they are doing. So comparing the Swedish approach to anywhere else is probably not ideal because we can't. But if we take the example of the UK instead of Sweden, given the costs of the last lockdown, if there's a combination of non-pharmaceutical interventions that would keep this disease at a low level for many months to come, it is entirely possible, not guaranteed, not certain, that within the next few months to a year, that a vaccine will be found. And then some more months will be needed for that vaccine to be evaluated in trials and for the manufacturing facility to be established. If this disease is serious enough to lead to the shutdown of society, then the will can be found to set up the manufacturing ability to share those products, i.e. immunize people against the disease. The other alternative that could arise is the availability of effective medicines. And if that happens, then it becomes a treatable condition. And again, as long as you don't overwhelm your health system, then that path becomes an option in the coming months to a year. My view is that's a better path than assuming, especially as we don't know, that people actually do acquire immunity to this. So it may be several cycles of tens of thousands of people dying.
Right. Well, that all makes sense. And one final thing on the sort of British situation, which I'm asking really more just to scope out the position rather than just to talk about Britain incessantly. The relaxations that have been announced recently, some epidemiologists are saying this risks super spreaders. It's dangerous to have a cleaner in your house. It's dangerous to send people back to work because they're going to have to use public transport. They're very nervous that we've jumped too soon. Other people are saying, no, we can't let the economy go down. These are just about consistent. Well, I mean, obviously, the chief medical officer, the chief scientific officer must have taken this view. These changes, if they're abided to, are just about enough to get the economy going without having that effect of pushing our above one. Were you in the comfortable or uncomfortable camp?
So I sit somewhere in the middle of those two camps. And I'll tell you why. So if you think about it, it's not really a question of whether we should lift the lockdown or not. At some point, we have to do so. It's a question of, are we ready to do so in terms of the preparations that we've made? The non-pharmaceutical interventions that have been used by places like Korea, to some degree by the Germans, etc., including testing of people, ensuring that contact tracing is at scale, etc., have all been bought by the state here, and they are planning to do so. And I think many of the critics that disagree with the government are saying we are not ready to do those yet, and we're opening too soon, rather than we shouldn't open society. And as long as you do it slowly and you make sure that those interventions are ready, and that you keep monitoring, as the government has said they will do, and if there's any signal that this approach isn't working, they will shut down quickly, then it's possible to contain this disease in limited geographical areas before it spreads through society with those interventions. So the truth is somewhere in between.
Well, let's move on to the sort of the equality and the disease. First of all, sort of within a society, and then between societies. Before we move on to the BAME issue, because that's obviously been one issue, are you of the view that this is that so far, and I haven't really seen the data, maybe you have, that this has been something that has particularly affected the most socially and economically vulnerable, as well as the older? Or is it actually true that it's not a great respecter of any kind of wealth or privilege?
So it's interesting, actually, how this disease started. If you think about it, from Wuhan, it spread to all the wealthiest cities in the world. And that's because of the privilege of those that can afford to travel and bring the disease with them in different places. So whether it's Paris, New York, Milan, or London, that's where it started. But once it gets a niche in these cities, it's not really also surprising that for an infectious disease that can affect anyone, and it can affect anyone, it tends to be more successful in those that lack the ability to be able to protect themselves. And by protect themselves, I mean, if you're in a job where you have to be in a public facing role, whether it's driving a bus or cleaning a hospital, then you have a decent chance of being exposed to it. Compounding that is those people without the will also are live in the most crowded settings and houses. They are more likely to travel on public transportation with a lot more other people to be exposed to. They are more likely to congregate in social or religious circumstances that exposes them to the infection. So there's a whole exposure angle. And then once people are infected and it's spreading in those communities, they also lack the ability to seek prompt care or to self-isolate effectively and prevent further spread. So there's ample data now from almost every place where this disease has spread, that while the initial process is that of disease brought in the affluent bits of society, once it takes hold, it exerts an unfair role on the most vulnerable among us and the poorest.
And do you see the elevated rate of deaths among ethnic minority groups as primarily a result of those people being less well off, or do you think there's some other genetic or other biological or social reason why this has taken place?
So this is one of the issues that actually infuriates me. It's, I think, almost intellectual laziness to jump to genetic excuse without excluding the obvious socioeconomic drivers in front of us. I think there will be time to do analysis, elegant analysis of genetic factors or similar, but there are huge socioeconomic differences, including examples that I've just given, but also examples in terms of access to healthcare and the treatment people get once they get access, and how they're differentially treated and the sort of health services they access because they happen to live in a poor area. I think it's reasonable as scientists that once we account for those and then we can see differences remaining, then we could look at the whole genome sequencing of human beings and then decide whether there is in fact a genetic driver. On top of that, there are also diseases that are genetically driven that increase susceptibility, including, for example, diabetes that is more common in certain ethnic minority groups, which is also environmentally driven in terms of what diets people take and their ability to exercise or gain weight. And all of those are underpinning the ethnic drivers. And before we jump into a single gene or a multiple set of genes or interactions of genes, we really ought to deal with those because they seem to be the obvious ones.
Yes, it sounds very logical. Now, let's move on to the international position. So some people are saying, look, this started with well-off countries. Bill Gates is very worried about this always. The moment as it begins to spread to countries which are less well-off, their health sectors are less well developed, their health capacity will be quickly overwhelmed. This could really represent a big disaster for those places. Other people are a bit more sanguine. They say, look, the age composition of those places is different, and the climate maybe will have a role to play, and that's different because people are more outside than inside. Again, those are optimists and pessimists. Are you in the middle on that too?
I don't always sit in the middle.
No, I wasn't suggesting that. I was just putting the question.
So yeah, very good question. I think that those, especially on the African continent, and several of my eminent colleagues on the African continent have said to the West, in the case of COVID, you have your problems, worry about them. This is not hitting us in the same way as yours. We are not going to have Northern Italy or Wuhan or London here for the reasons you outlined. I think it's a little bit early and premature to jump to those conclusions. I think that the rapid shutdown, as effectively done, I think South Africa probably provides the best example of that. Very effectively done, has slowed down the spread of the disease to such an extent that we really do not know yet that if cases suddenly arise in homesteads or some of the bigger urban slums in the major cities of South Africa, that it won't spread and cause devastation at levels that are comparable to China. And until we do that, it seems to me unreasonable to plan on the basis that somehow we're just going to be lucky and it will play out differently. If I turn out to be wrong, I'd be very delighted to be wrong that lots of people aren't dying, but that they've planned adequately. And lots of African countries have not done what South Africa have done. And I know, and I'll come back to this in subsequent questions, there are lots of things we can critique and challenge the South African government that they haven't done, but there are also a number of amazing things building on the excellent work of our TB and HIV colleagues that they have done that is exemplary.
So some people have said, look, you know, the World Health Organization is a vital organization for providing information and assistance to these countries. The last thing we should be doing is undermining their work in any way. Other people say as well, yes, we shouldn't be undermining them. Yes, Donald Trump is an oaf. But on the other hand, the reaction of the World Health Organization probably wasn't its finest hour. They probably overreacted to overreacting on previous occasions, and now they've kind of underreacted, and maybe their relationship with China has got something to do with that. Are you a critic of the WHO, or are you a little bit more understanding?
So I think there will be time again to look at how WHO has handled this incident, and I am certain that there will be a lot of lessons and critique to be leveraged in terms of what they did or didn't do in response to this. But I think the premise for me is, what exactly is WHO empowered to do? What are they really able to do? They have an annual budget of what, $2 billion or thereabouts, a large chunk of it a year, and a large chunk of it already earmarked for specific activities by the respective countries. They are not the equivalent of Public Health England or the Department of Health in South Africa. They do not have the might or ability to tell any country what to do. They are told what to do by the Committee of Nations. And when two elephants decide to fight, and this goes way beyond COVID in our geopolitics, China and the USA have this imagined rivalry that would shape our futures. And they choose to do it with the WHO as essentially the man in the middle or the woman in the middle. And I feel that some of the critique is inevitably going to be unfair because it's an impossible position to be in. They've done a number of good things, including very clear signals to countries in terms of what to do and what not to do. And they've done certain things that, with the benefit of hindsight, I personally would say, was that the right decision? And we can come back to that.
Can I just ask you two things before we move on to the audience and to its questions? The first thing is, at a government level, what can now be done by wealthier countries to help less well-off countries cope with what may, and we agree only may be, coming of this pandemic?
Be less selfish, and I mean that literally. Be less selfish in the sense of not just the rhetoric saying we are going to donate 200 million to the government of Rwanda. No, be less selfish in truly thinking about what do these countries need and how can we provide them. And I say this, and I'll illustrate it with an example. Right at the beginning of this epidemic, the European Union, which is in the context of today's politics globally, one of the ones that is most sympathetic to the cause of poorer nations, compared to many right-of-center governments that are a lot more hostile about that sort of sharing. But they came up with the rule that says no company can sell products that are needed for COVID-19 response without the explicit permission of governments. So essentially, even if you have the money, you couldn't buy the products you need for testing, for PPE, etc., from the European Union because they want to reserve it for their people first. Now, the consequence of that is, even when they don't need it, even when they have excess, it would be accumulated and stored, and they would probably keep supplies enough for the next 20 years before eventually they release it. And that has real implications for many, many poorer countries, because unfortunately the industries and the factories and the know-how does not exist to produce many of the things that are needed. So my answer is be less selfish.
Thank you. And then before just moving on to these questions, a very quick one. Is there anything that the participants in this Zoom call can personally do to help?
Absolutely. So I think this is my opportunity to pitch for this charity. I think ultimately governments in poorer countries have very shallow purse, and therefore they are unable to afford all of the things that they need to do. And if we are to succeed in this battle, especially if the sort of London-Milan scenario pans out, is community organizations and community action that would make the difference. So what you can do is, in fact, empower those that have systems and people in support. And in places like South Africa, it's actually the people that have been working with women and children, with people infected with HIV, that have systems in place that would allow us to support the people that are most in need and to empower them to protect themselves. So the one thing you can do is actually to give generously to such organizations.
Thank you very much. Well, I'm going to go on to the questions. Can I tell people have sent me questions in the Q&A, and if you've got one, you should add that to the Q&A button, which will be on your iPad, or if you're on a computer, on the bottom of your screen. Please excuse me if I mispronounce your name, because I'm reading them off and sometimes they're typed in one, and this first one as an example, I think it's Jordina Evans. Professor, given the divergence of views, what do you estimate the death rate from the viruses? I think that means what is your view on the infection fatality rate?
Right. So I think this is my chance to give a short lesson on epidemiology, infectious disease epidemiology. So the reason why it's been incredibly confusing is that there's something called a case fatality rate, and there's something called an infection fatality rate. The case fatality rate refers to people who present with symptoms of the disease, people that you can recognize and test, as the denominator. And then on top of that, you put how many people have died as a consequence of that. And the division between the number of deaths in people with the disease divided by those that are symptomatic and present with the disease, is your case fatality rate. The infection fatality rate, which I believe is what you're asking for, is yes. a slightly different metric, which is of all the people infected, and many of them would be completely asymptomatic, and we believe that that's a large proportion of them. Of all of them, how many people have died? And you divide the number of deaths by all of those infected. And as you can see, therein lies the problem, because if people are asymptomatic, many societies have systems, including, for example, in the UK, where we chose to prioritize only testing hospitalized people. We don't actually know that big denominator. So estimates of that infection fatality rates have best been measured by, for example, people in instances where an outbreak happened in a cruise ship, where you can measure test everybody and then get your denominator correctly, and then get a numerator, i.e. the number of deaths based on the people who have died. And the estimates from those suggest that this disease kills somewhere between 0.3 to 0.5% of people as the infection fatality rate. Others argue that those are unusual and intense situations, and therefore it's likely that the infection fatality rate is exaggerated, and that it's a lot lower and closer to what seasonal flu does, which is about 0.1%. And others say, actually, no, that's not representative. It may be a bit higher and will be somewhere under 0.1%. My view is it's clear to me that this isn't seasonal flu. Too many of us, we've never encountered it. We're all unimmune to it. And therefore, it would be surprising if something completely new that can kill people turns out to be as low as that. So it's probably right that the figures of about 0.3 to 0.5 are the correct ones.
Just sound credible to me too. Martin says, what are the likely consequences of us accepting a higher mortality rate for the medium term, at least, if we also accept that we're not actually just one herd? Certain groups in society appear to be more susceptible than others, and will have, and this is what he says, will have higher inherent R rates.
Right, so that's interesting. That's a concept actually that epidemiologists have also grappled with. So as opposed to a vaccine where we vaccinate people randomly, if you allow an infection to spread, it's not surprising that the people that are most likely to get it are also the most effective of the disease. So actually the herd immunity threshold may be lower in the context of vaccine, because you are removing people who are more likely to spread it first, which is a difficult concept to grasp. Unfortunately, we don't have evidence that that's the case, primarily because we don't actually still know whether this gives protection, and if it does protect you, for how long does it do it? I accept that in addition to what I've just said about the spreaders, in terms of susceptibility and also adverse outcomes, we're also not all the same, and that some communities, including the ones I mentioned, the poorest in society and the elderly, have a higher toll, and that others argue, I would say perhaps selfishly, that why should we all suffer if it's a subset of the communities that would bear the brunt? I think that there's a moral and ethical imperative to look at the path that minimizes the toll on those individuals as long as we can afford it as human societies. And that path probably sits on the lines of doing all we can in non-pharmaceutical interventions while allowing societies not to break down in terms of economic chaos.
So we've got a couple more questions and then we need to wrap up. But Julia Bishop asks, what do you think the North can learn from the community health worker model that is embedded in health systems in the global South and that is being leveraged to combat the disease?
Take us back to Margaret Thatcher. There's no such thing as society, or whoever said that. There is something like society, and the difficulty of doing things like contact tracing or of reaching out to people is complicated in settings where, in fact, there isn't a community. And I think from my experience of working in London, where I've tried studies in large numbers of people across London in tuberculosis, and where I go to Hindu and Sikh communities where people gather in their temples every weekend, the ability to get messages and deliver interventions is amazing. You would be surprised to hear. And I think that there are still communities like that in London, largely around religious communities. So the Jewish communities in North London, as well as the Hindu communities, are effective at that. And such things still exist here. The question is, how can we then replicate what many developing countries have, which took them years to organize, building on networks of the interventions around HIV. I think it is possible to do that. I think the shock that this disease is sending through society would enable us to stop and reflect on what do we want to be like going forward. And maybe one of the things that ought to be on the table is this very issue. How can we restructure society so that we look out for each other a lot more?
Fine, and thank you very much. And then finally, an interesting question this, because I don't really understand the answer to it. Why are more men than women dying? And is there anything we can do to protect them further?
So the truth to that is, I actually think I do not know the answer to that. And sometimes epidemiologists have to say that. I think we're still learning. There are instances where the data suggests that the mortality rates are disproportionately in males. And then there are places, I've seen some Canadian data, where actually it's a lot more equal. And when you begin to break down those data by age group, again, it gets more complex. So the age groups where it's more common in women and where it's more common in men. For the places where there's a disproportionate toll in men, it's probably a combination of factors. Possibly men being the ones that go out more and get exposed. Possibly men having the comorbidities that increase the risk of dying. So whether it's indeed the wrong forms of overweight or the chronic diseases such as diabetes and hypertension, or a number of those. So I think we're still learning, and I think the answer to that would emerge as we learn more about the epidemiology of this disease.
Thank you. You know, one of my dreams in the last couple of weeks has been if only I could get a professor of epidemiology and sort of sit them down and really ask them every question that's on my mind and then get to probe them and they would answer. Wouldn't that be magnificent? And I've had that chance today. It's been as riveting and exciting intellectually and as hopeful, but also, you know, worrying and concerning as you might imagine that it is. And your time and also your eloquent words on behalf of the charity are really appreciated. David, I'm going to hand over to you to close the event.
All right. Thank you, Danny. That was Danny and Ibrahim. That was, as you say, riveting, fascinating, and fresh. I mean, to me, this was fantastic because this was like not the same old. This was real, you know, that we hear night after night, even on great television. And if you go on CNN, you hear a particular view. But so thank you so much, both of you, and particularly Ibrahim, for your insights and clarity that you've given us all. Thank you for mentioning that people like us, charities and organizations like us on the front line, are best placed to deal with things going forward. We are awaiting the release of the lockdown in South Africa, just one more stage when we'll be able to get out into the communities. We have people living in the communities. People like Kalulwa that you saw are actually in every community, and we cover the size, a geography almost the size of Wales. So the impact of having people on the ground who are well trained, know exactly what they're doing with healthcare, and as you say, mother-child healthcare is at the root of a lot of the issues that we face in society, including HIV and TB in South Africa. So there's a link that'll come up on the screen now as to how to donate if you haven't already. We've got another great seminar coming up in 2 weeks' time with Baroness Helena Kennedy, with Daniel again in the chair. And that should be fascinating because there we're talking about the rule of law and human rights, and it fits very snugly alongside the conversation that we've had today. So thank you again. Thanks everyone for being here, participating on this call. Thanks for your questions, and we'll be in touch again soon. There should be a recording available in case you tuned in late or you want to send it to friends and colleagues. So have a good evening, everyone, and thanks again to Danny and Ibrahim in particular, and to Kalulwa in South Africa, and the whole team out there who are doing such amazing work. Thanks, everyone. Good night.
Good night.
Thank you. Good night.
Good night.